ngende kupata wifi. Kigali no ufite nakidore. Yera kubesha man. Ari tarenze.
If you're late, of course, you can join me here. So let us start. I'm the only one singing. I have a good voice, eh? I used to sing in the choir back at home.
There's no cheating.
VAR. Okay. I will make you fishers of men, fishers of men. Men. Okay, let me give instructions for men. They are saying that I'm a feminist. So for men, this is how you will behave. I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow me. Any M is men. Any F is female. Okay. How many dancers do we have? Two people are not good at taking instructions, eh?
Joining us. Now we have all fishers of men in the room. Thanks, Idel. So, as I was introduced earlier, my name is Karen Neal. I work for the King Faisal Hospital Rwanda team as well as Africa Health Sciences University. So I've been working here in Rwanda for the past 11 years, so it's my home. So for those of you who are visiting, you're all welcome to Rwanda. We're happy to have you here. So for the afternoon session, we have a few adjustments to the schedule. We're going to have 3 oral abstract presentations. After that, we're going to close the session in here for the day, and we're all going to go out to the main entrance where you entered from, and we're going to take a group picture, okay? So we'll go there right at the end, and then we will close the day with a tea break, which is a good chance to network, meet someone you don't know, and close out the day, okay? So without further ado, we would like to get into the first oral abstract presentation, which is by Ada Esther Ozoimena, who will be presenting on assessment of mental health of pregnant and postpartum women attending antenatal and postnatal services in tertiary health institutions in Anambra State, Nigeria. So Ada Esther is a public health nurse educator and a lecturer at the College of Nursing Science, Nnamdi Azikiwe University Teaching Hospital in Nigeria. Her academic and research interests focus on mental health, with a particular emphasis on mental health challenges among pregnant and postpartum women in tertiary care settings. She has collaborated with Diorgu on this project. So without further ado, please join me in welcoming our presenter to the stage. Thank you very much.
Good afternoon, everybody. I think there will be no need for further introduction. Like she said, I am Ada Esther Ozoimena from Anambra State, Nigeria, presenting on the topic Assessment of Mental Health of Pregnant and Postpartum Women Attending Antenatal and Postnatal Health Care in Tertiary Health Institutions in Anambra State, Nigeria. Before I go on with the background of the study, let me start with mental health. If I ask any one of us here, I think you have a mental health, I feel that you will get angry that maybe I'm trying to curse you or I'm trying to insult you. But in one way or the other, each and every one of us has a little bit of a mental health problem. It could be anxiety, it could be depression, it could be PTSD. So whichever way, by definition, mental health is a state of mental well-being of an individual, being able to cope with the stresses of life, learn how to work well, and adapt to the activities of life, and also being able to participate in the community. Pregnancy and postpartum period increases vulnerability to mental health disorders such as depression, anxiety, psychosis, and post-traumatic stress disease. In low and middle income countries like Nigeria, these issues are often underdiagnosed due to the stigma, poor service integration, and limited awareness. Yes, because you will hardly find anybody feel comfortable to tell you that, oh, I'm depressed. They will look at you like, is she okay? Which one is she? You are depressed. That you should come off it. So this study aims to assess the mental health status of pregnant and postpartum women attending antenatal and postnatal services in tertiary health institutions in Anambra State. So, maternal mental health problems during pregnancy and puerperium are major contributors to maternal morbidity and mortality and have negative effects on the health and development of children. In low and middle income countries such as Nigeria, where I come from, the prevalence of antenatal depression can be as high as 31.6%, with postpartum depression rates reaching up to 35.6%. Many healthcare facilities in Anambra State, they focus primarily on physical maternal health, neglecting the mental well-being. I think I'm a first witness of this. While I was pregnant with my third issue, I was studying and I was pregnant. So at some point, I went to the antenatal to see the guy in there. I told him, see, I think I'm no longer concentrating on my studies. I can't read. Even if I read, I can't retain them. He said, oh, you'll be fine. And that was just it. So nobody looks at this to see it as a problem. And I think it's a very major issue that should be considered. So in Anambra State alone, there is limited data that exists on the exact mental health disorders among pregnant and postpartum women. The aim of the study was to assess the mental health of pregnant and postpartum women attending antenatal and postnatal services in tertiary health institutions in Anambra State. The objectives are to assess the occurrence of depression among the respondents, assess the occurrence of the anxiety among the respondents, assess the occurrence of psychotic syndrome among the respondents, and assess the occurrence of PTSD among the respondents. My research aims to answer the following research questions. To what extent does this depression occur among pregnant and postpartum women attending these antenatal and postnatal services in tertiary health institutions in Anambra State? To what extent does anxiety disorder occur among pregnant and postpartum women? To what extent too do psychotic symptoms manifest among pregnant and postpartum women? And to what extent do post-traumatic stress disorder manifest among pregnant and postpartum women attending antenatal and postnatal services? Okay, these are the hypotheses and literature review. Okay, worldwide, among about 10% of pregnant women and 13% of women who has given birth experience a mental disorder, primarily depression, because of the high level of, like in Nigeria alone, you can see a pregnant woman, she has little kids to cater for, she has a family to look out for, she has work, she has a lot of things. So that alone, in developing countries like Nigeria, there is also even higher, that is 15.6% during pregnancy and 19.8% after childbirth. I think that is right, because after childbirth, you have a lot of things to do. Sometimes the parents might not be around to take care of them, especially for those that have lost their spouse, their parents, or those that doesn't have anyone to take care of them at that perinatal period. It's usually a very stressful period. So some also cultural stigmas surrounding mental health often lead to underreporting and reluctances to seek help among affected women. A woman can be, after delivery, she'll be like, oh mom, I feel that I'm feeling depressed. They will shut her up. What do you mean by you are feeling depressed? Is it not the same way Auntie Joy gave birth that you also gave birth? You know, they will try to compare you with others. And the next thing, you wouldn't want to speak up. That was why recently, I think it has reduced. We had incidents of a woman after giving birth, they will try to kill their baby. They will try to start their baby. Even when you talk about puerperal psychosis, they'll be like, which one is puerperal psychosis? So this aspect of the maternal mental health problems not only compromise the mother's well-being, but are also linked to poor infant health, delayed development, and reduced breastfeeding practices. It's only a healthy woman, a mentally stable woman, that can be able to take care of the baby. She should be able to take care of herself, not to talk of taking care of the baby. So socioeconomic factors like low education, income, and occupational status, along with psychosocial structures such as loneliness and child illness, have been reported to correlate with poor maternal mental health outcomes. Jidong et al. In a systematic review on maternal mental health and child well-being in Nigeria, they identified 5 themes on maternal health concerns, which are the marital difficulties, the relationship status of the mother, the child's gender, mode of child delivery, and child growth development. When you talk of the child gender, some women can be depressed, like, oh, what? Nurse, please, what's my baby? What's the sex of the baby? And you know, we value this male, there's this male preference syndrome, yes. Like, and if it's a woman that have given birth to like 4 girls, it's going to be she's going to be in a lot of anxiety, especially when they cannot afford to go for an ultrasound to identify the sex of the baby. It's usually a problem for them, and for those, especially if you have a woman delivers through cesarean section and there's nobody to look after her, she can't endure. Is it the pains from the scars? Is it the cries of the baby at night? It's a lot of things there. So, and also, Allah et al. In 2024, they observed an inverse relationship between breastfeeding and mental health disorders among nursing mothers in Nigeria. Oh, I don't know if you have sat down beside a woman that has breast sore. She finds it very difficult to breastfeed their baby. In fact, whenever she remembers that, oh, I want to breastfeed this baby, they get this kind of anxiety because they already developed sores at the breast and they can't breastfeed that baby, and it causes a lot of mental instability for them. This study employed a cross-sectional design. The study population comprises of 1,604 pregnant women The study was done in Anambra State, a southeastern state in Nigeria. Sample used was pregnant and postpartum women attending antenatal and postnatal services in the selected tertiary institutions in Anambra State. Out of the three, because we have 3 tertiary health institutions in Anambra, only 2 tertiary health institutions were selected through simple random sampling, which are Nnamdi Azikiwe University Teaching Hospital and Federal Medical Center, Onitsha, because of the high inflows of patients that they do experience. The study population comprises of 1,649 pregnant and postpartum women attending antenatal and postnatal health services in the selected tertiary healthcare institution, which proportionate stratified sampling was used to determine the number of participants to be drawn from each hospital. 60% of the data population was gotten from Nnamdi Azikiwe University Teaching Hospital and 40% from Federal Medical Center, Onitsha, based on the record of these 2 facilities. Estimated population of the women who attend antenatal care and postnatal services for the period of 6 months. The sample size used was 310 women. Data were collected using a self-structured developed questionnaire. Ethical consideration and informed consent were gotten. Items were rated on a 4-point Likert scale. Data obtained were analyzed. Inclusion criteria were pregnant women attending antenatal clinics in any of the selected tertiary health institutions, postpartum women within 6 months after delivery who attended postnatal clinics in the selected hospital, women who are willing to participate and provide informed consent. Exclusion criteria, pregnant and postpartum women receiving care in private healthcare facilities. Women with known pre-existing psychiatric disorders diagnosed before pregnancy. Pregnant and postpartum women who were critically ill and unable to participate in the study. Okay, I've talked about the data was collected using a structured questionnaire. Then the results of the study. These are the social demographic characteristics of the respondents. We had more of the women between the ages of 25 to 31 and less number of women between the ages of 18 to 24. And distribution of the pregnant and postpartum women. We used more of, from here you can see we had 60% of pregnant women and 40% of postpartum women. Opinion of the respondents of the occurrence of perinatal mental disorders. From the study, women they exhibited psychotic symptoms. There are women with, Okay, there are women with high level of psychotic symptoms, followed by PTSD, then anxiety disorders with depression, the less experienced. From the hypothesis testing, with the p-less valued as of 0.05, which is considered significant because I did some hypothesis testing. These values on anxiety disorders, psychotic symptoms, and PTSD are statistically significant, meaning that there is a significant difference in the opinion of the pregnant women and postpartum women regarding the extent of occurrence of anxiety disorders, manifestation of psychotic symptoms, and post-traumatic stress disorder. Then for depression, it has a p-value of 0.09, which means that there is no significant difference in the opinion of pregnant and postpartum women regarding the extent of occurrence of depression. Then the findings of this study, it revealed a high extent of depression, anxiety, psychotic symptoms, and post-traumatic stress disorders among pregnant and postpartum women, which post-traumatic stress disorder was the most frequently reported mental health concern, followed closely by psychotic symptoms, anxiety disorders, and depression. Reason is that The reason for the post-traumatic stress disorder is that they said, especially women that it is not their first time being pregnant, that they will say, oh, if I remember my previous experience, I have this kind of chills, I get scared of getting pregnant again and the rest. So the findings of high occurrence of depression and anxiety are corroborated by findings from Wang et al. And Naja et al. However, previous studies reported low incidence of psychotic symptoms. But I wonder why this, at least for the tertiary health institutions that I did, we had high incidence of psychotic symptoms. And the high occurrence of mental health disorders among pregnant and postpartum women observed in this study aligns with findings from various global studies. It is a global issue that is neglected, let me use the word, but I'm glad that recently a lot of facilities are now beginning to attach mental health clinics to their antenatal clinic and the postnatal clinics. Factors such as domestic violence, economic hardship, lack of social support network, pre-existing mental health vulnerabilities, hormonal changes, fear of childbirth have been reported to correlated with a high risk of perinatal health disorders. Overall, our findings align along with those from previous studies highlighted a critical gap in the adequate provision of mental health resources in antenatal care settings, particularly in the low-income countries. For the limitations, our study focused solely on tertiary health institutions, limiting the generalizability of findings to women in primary, secondary, or rural healthcare settings. The use of a quantitative methodology limits the exploration of cultural, emotional, and contextual factors shaping the maternal mental health experiences. Because if this study could be carried out in a qualitative research design, I think we can be able to have an in-depth insight of what we want to get. And this study did not include a follow-up or longitudinal component, limiting the possibility to assess changes in mental health status throughout pregnancy and postpartum period. This study also did not explore the causal relationship between factors such as socioeconomic status, social support, or history trauma, and the mental health status of the respondents. I recommend that maternal mental health disorders are common and likely under-recognized in tertiary facilities in Anambra State. Like in Nayut, Nnadazikwe University Teaching Hospital, where we come from, we don't have it. And indicating a silent public health crisis with potential negative consequences for maternal and infant health. Maternal mental health can derail both short and long-term health outcomes for both the mothers and infants. Hence, early detection and intervention are crucial. Integration of mental health screening tools into the routine obstetric care is of urgent importance. In conclusion, mental health disorders are prevalent among pregnant and postpartum women in tertiary health facilities in Anambra State, underscoring the need for routine psychological assessments as part of maternal care. Because when you go for antenatal, I think the only thing we do is just to do the normal routine tests, blood analysis, urine analysis, physical, they'll measure the abdominal and everything. Nobody cares about how do you feel. Even sometimes I think in my second pregnancy, when I entered the doctor's office, he'll be like, okay, he won't look at your face, he won't look at the facial expression, he will just be writing. Until one day I had to walk out on him and said, no, you're not going to see me again. Because you don't give me time to express myself, to know how I feel. So strengthening the capacity of healthcare providers through targeted training in perinatal mental health, alongside integrating mental and physical health services, can improve early detection and management. Community support structures should also be encouraged. Let's also involve the fathers, the relationship, everybody in the community will sensitize them on the need of mental health well-being, especially in the prenatal and the postnatal period. Community support structures should also be encouraged to significantly mediate the mental health outcomes. Efforts at public awareness and community education of maternal mental health should be increased. I suggest that combine quantitative surveys with qualitative interviews or focused group to explore the emotional narratives and social cultural contexts that shape maternal mental health should be carried out, please. And also explore the relationship between maternal mental health and possible predictive factors such as socioeconomic status, number of children planned or unplanned, and all these unplanned pregnancy. I think we have that unplanned pregnancy has a lot of, you see the woman, she goes inside, she wouldn't want you to see her, and our people trust us where I come from. They be like, again? So sometimes some of them will want to stay inside, they wouldn't want to socialize. So investigate the barriers to mental health integration during perinatal care, as well as the knowledge, attitude, and practice of healthcare workers. In fact, I should have boarded these healthcare workers, because we as the healthcare workers, we have a lot of role to play in the assessment of mental health of our patients. It's not only all about giving them drugs. It's not only about taking their vital signs. So I think we have a lot of work to do in assessing their mental health. The authors acknowledge the management and healthcare professionals at the selected healthcare facilities for their support in this study. They really helped me. Ethical approval was obtained from the Ethics Committee of the University of Port Harcourt. The informed consent, like I said, was also gotten. Thank you, and these are the references. Thank you.
Note of your questions. We're going to do the 3 oral presentations, and then we'll take general questions across all 3, okay? So before going to the next one, I have a quick announcement. If anyone left their phone at lunch and is missing their phone, you can come see us. We have your phone, okay? All right, so without further ado, we're going to continue to our second presentation by Dr. Wunde Njinek Ubrain, who will be presenting on emergency room Foley catheter retrieval of an esophageal foreign body in a low-resource setting, a case report. Dr. Wunde is a physician at the Presbyterian Health Complex in Simeyang in Yaoundé, Cameroon. His clinical and research interests include emergency medicine and innovative resource-appropriate approaches to patient care in low-resource settings. So without further ado, please join me in welcoming Dr. Wunde to the stage.
Okay, hello everyone. Mwara Mutsusi. If I should go home with something today, at least you should know how to say good morning in your language. Yeah, and of course, I should know at least one meal, which was the Ikitochi. Forgive me for the pronunciation. So, before I start off with my presentation, I would just want to thank the organizing team for giving me this opportunity to present this work of research. And equally, I want to be very grateful to Prof for having this initiative and for giving young scientists a global opportunity to present their work on a global platform like this. It's quite inspiring and it gives us the zeal to go ahead. Most of us here have conducted research at the thesis level and end up leaving it in the lockers. Such avenues give us an open space to present our work and of course push for its publication. Thank you very much, Professor. And talking in this light, before I proceed, I would like to acknowledge the presence of my master in the home, who groomed me and supervised my thesis. I'm talking of Dr. Roland Chufo, to whom I doff my hat. He's just... So he held my hand from my initial years in med school to today, and I'm very grateful to him for his holistic approach to teaching and mentorship. So I want to proceed, like I was introduced, I'm Dr. Wunde. I work with the Presbyterian Health Services. The Presbyterian Church in Cameroon is the largest institutional church in Cameroon. It is a structure that is religious-based and it's headed by Health Services Secretariat, who proudly accepted me to participate in this event. So we're going to start. This is the plan we are going to follow for our presentation, and of course the audience is the one seated right here. I guess I'm speaking to the right audience. Am I?
Yes.
Yeah. So infants are most vulnerable populations to esophageal foreign bodies. You know, with the evolution in technology, child proofing becomes very difficult because parents tend to be more concerned about their technology, the work, and the children have very little or no attention. So they end up having things stuck up in their throats, and they present like this. 2 infants. We had 2 infants, one in the city of Yaoundé and one in Campbell. So this one is actually a case series of 2 cases. And on clinical examination, these children, we ruled out any signs of respiratory compromise, and a chest X-ray was performed, revealing a coin lodged in the upper thoracic inlet. Under mild sedation, with a Foley catheter, we successfully retrieved coins from these children. So, just like I said before, children have the habits of picking things from the floor to the mouth. So that reflex hand-to-mouth action is commonplace in infants, and they are involved in diverse domestic accidents. If they don't put in something corrosive in their mouth or stick them in something hot, they may put in something that may go unnoticed for days to weeks sometimes before we start having symptoms. And the ingestion of foreign bodies is very, very much common in emergency department, as revealed by a study that was done in Nigeria, in Sokoto too. It is predominant in the pediatric population and as well in the elderly and people who have mental illnesses. So the aims of this study is just a case report. The aim is just to present a novel and non-invasive technique applied to retrieve esophageal foreign bodies. And as objective, we thought of reviewing the literature to present this case and the method we used, and of course to discuss the potential risks and precautions that should be taken in this procedure. So we are asking ourselves, what is the data that's available on this procedure, and what are the steps involved in Foley catheter retrieval, and what are the eligibility criteria for this procedure. So, while reviewing the literature, we realized that the incidence of AFBs is at 4%, and with a mortality of about 1,500 patients per year in the United States of America. The young adult population is affected mostly in the context of mental illness. The former presenter just spoke about mental illness, and we see how far it could go, because at times there is this autolytic process that people tend to have when they are afflicted by certain mental illnesses. And about 10 to 20% of these require medical intervention. In Sokoto, in Nigeria, 12.2% of ENT cases in 2019 of these esophageal foreign bodies were coins, and most of them, that is 35% of them, occurred in males. The Foley catheter retrieval method is not a novel method as we think, but it's an ancient method that was first described in the mid-20th centuries. It offers a cost-effective solution to retrieving blunt radiopaque objects from the proximal esophagus. We highlight that it's the proximal esophagus because beyond the thoracic inlet, it becomes difficult to extract objects like this using the Foley catheter. It may require an open chest surgery to some extent, or endoscopy. So it is suitable when the patient is stable and there are no contraindications. For example, sharp objects, caustic injury, and all of that. So we are going to go through the contraindications in the next section of this presentation. It is primarily used in children because of their short and flexible esophageal segments, but in adults too it could be used depending on the context. So we conducted a descriptive case report documenting 2 clinical events involving esophageal foreign body extraction using a Foley catheter. To be eligible for this procedure, we want to check that the object is blunt, it's smooth, and it's radiopaque. Then it can be easily visualized with radiography, having a very, very easy assessment of the site at which it is lodged exactly. We should note that the object should not be chemically corrosive. It should be small to medium in size. It should not exceed the esophageal diameter. And concerning the location of the object, like I said before, it should be in the upper or mid esophagus. It should not be below the thoracic inlet. And the object should be accessible without excessive manipulation. And this, again, is going to play on the competence and expertise of the manipulator. And it is favorable, this procedure is favorable if it is if the object is well visualized on imagery. So now, in order to go on this procedure, in order to go on this procedure, we have to first start by getting informed consent, and then we encourage the patient to fast for at least 8 hours, because this is a procedure that's going to involve you sticking something down someone's throat. You won't want that person to vomit, especially the person under anesthesia, because the person may have a false route and may get you into more problems than what you are trying to solve. So insist on the patient getting fasted for at least 8 hours, and that the stomach is empty. You may even want to do a suction first with whatever material you have before you proceed. Then we proceed to administer mild sedation. I insist on mild sedation because you don't want to get the patient slipped over, because the gag reflex which you are going to initiate is going to be very important in retrieving whatever object you're trying to remove from the upper esophageal segment. Then we are going to proceed to a gentle insertion of the Foley catheter through the esophagus using anatomic landmarks. That brings us back to our level 1 and 2 anatomy, and then we need to aspirate to be sure that we are in the esophagus and not in the airways. Then we inflate the balloon once we are sure that we have gone past the object. Again, the object should be blunt, because the sharp edge, once you're pulling, you're going to be tearing on the esophagus, and that may cause an esophageal perforation and eventually a probable thoracic mediastinitis, which is going to be far worse than whatever you're trying to solve this. So the precautions, again, are very important. And you apply gentle controlled traction on the objects in order to take it out. So when we do this, what do we obtain? So when we did this procedure, I'll admit that the first time was difficult and we failed and we gave up, but we tried again and we succeeded to retrieve. This is a coin for those who are used to Cameroonian currency. That's the 100 francs coin that was previously lodged in the upper border of in the upper third of the esophagus, that's at the thoracic inlet. So this paper describes the procedure of retrieving an esophageal foreign body, which is kind of uncommon, but it's a practical technique. The primary treatment for object lodged in the esophagus remains endoscopic removal. However, in some settings, like in Cambe, where one of these cases is difficult to have this done with endoscopy. So we want to try other techniques. And Cambe is, for those who know a bit of Cameroon, Cambe is at the heart of the Northwest. To leave from there to the regional headquarters, where I don't think there's endoscopy up to now, for memory as well, you need about 7 to 8 hours of traveling if the roads are good and you don't have any interruptions. For those who know, there's a crisis in the Northwest now, so it's a bit difficult to transit from city to city. So this technique sets light on the possibility of having a similar result in a shorter time frame with very little or mild sedation. In a setting where expert critical care is not easily reachable, and with the notion of high cost accompanying such elaborate procedures, innovative, cost-effective methods are very, very pivotal in providing critical care to patients who are in emergency situations like this. However, we have some limitations to this paper. This is because it's just a case series with only 2 cases, and hence limited data on applicability of these findings on a large scale. So this is an avenue for further research to put in place an elaborate protocol or procedure for this procedure to be carried out. Now, following this research and the conclusion we have, we recommend that this technique is a revolutionary thing that should be taken. That is a potential breakthrough in the practice of urgent care medicine. If an extensive multicentric prospective study is carried out on this practice, it could establish a protocol that could lead to to the use of this technique in a more formal setting, and of course it could be harmonized to be used in other parts of the world. So, mesdames et messieurs, la sonde de Foley est une option très viable et mini-invasive pour l'extraction des corps étrangers ésophagiens. Son applicabilité est particulièrement pertinente dans le contexte des prévus des services endoscopiques avancés, démontrant ainsi l'adaptabilité clinique des soins d'urgence dans ces parties de notre globe. La réussite repose sur des critères d'inclusion stricts. J'insiste vraiment qu'ils soient vraiment strictement respectés, parce que en dehors de cela, c'est la catastrophe qui nous attend, comme j'ai expliqué ci-dessous. Cette technique s'inscrit dans l'objectif de soins de santé équitables en offrant une alternative peu coûteuse lors des disparités des ressources qui peuvent impacter le délai de réponse clinique. Merci pour votre aimable attention. Je suis très reconnaissant et merci pour nos références.
Note of your questions, because after this last oral presentation, we'll have time for any questions for any of our presenters today. So, now we're going into our third and final oral presentation for today, and we have Gaston Ndajijimana, who will be presenting on Digital First, equipping the next generation of health leaders with tech-driven problem-solving skills. So Gaston is a medical student, a public health advocate, and founder of Medigo Care Rwanda. His work focuses on harnessing technology and innovation to strengthen healthcare systems and empower the next generation of health leaders in Rwanda and beyond. So please join me in welcoming Gaston to the stage.
Faisal, for organizing this opportunity. Like everyone past here has thanked them, but really personally, because working on this project, we are actually lagging behind by a certain way. But after getting accepted to present, I and my whole team, you can see them, they were like really motivated to keep up. So we thank you so much. And for the organizers, I understand I've been in your places to organize such events, the smaller one to this, but I could feel the intensity of making this possible. Yeah, so we are going to dive into digital health. It's not supposed to be that much complicated, digital health, okay? So, by the way, I'm Gaston Ndajijimana, the founder of Medigo Care, as they said. What we do in medical care, we actually bridge technology and healthcare while building the next generation of healthcare workers who are digitally competent. So saying that healthcare workers who are digitally competent. So I would like to challenge anyone in this room. Do you think any health worker would need to possess a digital competence? So if you agree with me, please raise your hand. Of course, yes. So who do not agree with me? Raise your hand. Thank you so much. So you can see we almost now, everybody in this room agrees with me. Okay? Like a health worker needs to possess a certain level of digital competency. So now your question is, how are we preparing our healthcare providers to be digitally competent? How are universities, the training institutions now, are training healthcare providers to be digitally competent? Is even technology really important in healthcare? I think yes, right? Really, yes? Okay, so we've had even Menlas from MOH has tried to demonstrate what our Ministry of Rwanda is now doing in healthcare, integrating AI in surgeries. We are seeing mobile health solutions. Really, it tells how much the technology is transforming healthcare from medical practices to public health practices. So now, this research topic now, we are going to dive deep into it to see then if you are needed to possess certain level of digital skills, what are those skills? And what the problems do those skills are going to solve? Okay, yeah. So recently I attended youth in Digital Health Network. I was really honored to be selected by Africa CDC to join the training that happened in Ghana. Do we have any Ghanaian in this room? Ghanaian? Oh, really sorry. Like I was supposed to, compliment them. Like they have really good dishes. Yeah. So if you see one of the Ghanaian complaining your dishes, like here in Rwanda, don't mind them. They're just comparing their dishes to ours. They are really good. So joining Africa CDC, I was able to see how the training gap in digital skills for healthcare providers, it's not specific for Rwanda's context only, but for the almost Africa. And then the opportunity now we have is that not unlike any other continent, Africa has high penetration of mobile tools. We use mobile phones more than any continent in the world. So Africa CDC and WHO sees that as an opportunity to achieving universal health coverage. So they say this narrative, if I'm able to put your doctor in your pocket, we are achieving universal health coverage. How then are we going to put a doctor in your pocket? That's mobile health. So as everyone who has a phone to have access to healthcare services. You see? So digital health tools are very important. More than that, during COVID-19 pandemics, no one was able to reach out to anyone, for any contact was restricted, okay? So what tools then supported us in those terrific times? The digital tools. That's where even technology mostly striked. That's how many even innovations came in place. You see how digital health is so much important? Speaking on that, people in remote areas who do not have, who need to travel long distances to their hospitals, what if they can access the information on their phones? So now you know that the problem. Through the literature review, that you conducted, we've seen that one of the challenge we are seeing that restricts the success of mobile health is that we are having healthcare workers who are not digitally competent. So the tools we are using are being developed by technicians, ITs, and then you know the problem. Now the tools become like they do not speak to the real challenges of the people. Why? Because people who developed them, they were not able to have exposure to the real challenges like the doctors, nurses, and pharmacists do, and many others. So developing then, building the digitally competent health workers who can be part of the teams building such amazing tools will be a success to universal health coverage. So then, doing our work here in research, we were able to see what skills then the healthcare provider need to possess. They are being categorized into two umbrellas, which are e-health and m-health. E-health concerns ICT-based platforms that modernize healthcare delivery. Those include electronic health records, by the way, and now 70% of hospitals in Rwanda now uses electronic health records. We are transitioning from paper-based medical recording to electronic. And this shows the transitions we are now doing. But you know the problem? Recently I was part of a research project and we were conducting DERAs and we had around 15,000. So, you know, we need to clean them before proceeding. So after cleaning, we were able to remain with only 2,000. You know the problem? That means that the records we had, many of them were incomplete. Some DERAs were not even included. And that made us to have only 2,000. And this tells how much really we need even to train people, the people who are assessing the electronic health record systems, the way proper to enter the records. You see? So also the mobile health concerns mobile-based health services, widely scalable in low resource settings, as I told you. Developing some tools like mobile health tools, which can be accessible by anyone on their phones. There is even a way that we do develop USSD code. I don't know if you guys know it. You probably know it, yeah. People from remote areas who do not have access to internet can access healthcare without even internet. Do you imagine? So global evidence also, as I told you, shows that training must be structured, early and continuous. So as to have digitally competent health workers, we need to set a tone of developing digitally competent workers. So Rwanda has high penetration rates in Africa worldwide, and a strong digital innovation ecosystem. As you can see, Rwanda is investing much more in opportunities for youth who are innovators, who are, really wants to address the community challenges. We've seen hunger, hunger. We do have hunger, also SRH, they are two different. And we do have many of others that are providing the funds, the training capacities to the youth who are in digital health. So, and you know what's really funny? I recall like the last time we were being selected to join Youth in Digital Network by Africa CDC. One of the criteria were that you need to possess some digital skills, And as a medical student, I was not supposed to have one because the university was not giving one. You see the problem? But I could go online, search some digital courses and do them, and to have something to talk about during the interview, But that should change. We need to have extracted learning. We've seen how really it must be important. Okay. Yes, so doing this research then, we have three main things in our mind. So we were asking ourselves, do really healthcare students in Rwanda receive adequate digital health training? We wanted to confirm. Also, what prevents adoption of e-health and m-health in curriculum? And we didn't also bring up the problem only. I and my team, we are proposing a solution, trusted. So we were also assessing the students' use and understanding of digital health, and we made a questionnaire regarding the recommended digital skills by undergraduate healthcare students. In part, it was called DCODE framework. DCODE framework was done by WHO to guide training universities and institutions training healthcare students to guide them to integrate healthcare skills, digital skills in their curriculum. So we then followed the framework in structuring the Google form questionnaire. So the problem is not only in Africa. We've seen that also in Europe in 2016. The survey conducted among healthcare providers, 79% they saw e-health and m-health. You remember what we call now e-health and m-health. And as the transformative, they see this e-health and m-health as transformative for healthcare. And the problem is still the same. 61% lack the training. So Rwanda mirrors the infrastructure investment, we have it, but weak training pipelines for undergraduate healthcare students. So we are proposing then a web application like integrated with the e-health and the mobile health digital skills, tailored for undergraduate healthcare students. And this was designed according to what the solutions we've seen from our research. Okay, so yeah, the form, we have 300 responses from across the 7 universities training healthcare students, including University of Rwanda, UGHD, Asome, and we could get 300 responses. The methodology was mixed, was cross-sectional mixed methods, both qualitative and quantitative. And the student this, we mainly focused on final year medical students to see how are they now leaving the universities digitally competent, what level and what the gap that they have. So then we come here to the results. So we saw that there is a need of creating a platform, as I told you, that features the digital courses that are needed by a healthcare student. And we developed the platform in 2 sections, where the healthcare student will first of all have the training on digital skills, but also get time to use the skills addressing the real problem we have in our communities. Because as of now, once we get into year 2, year 3, we start moving around the hospitals, and we anticipate that maybe you've seen your own challenge, but the problem is you do not have the knowledge to think digitally into the solution to address the problem. So equipping then every healthcare student with such digital competence, we spark the innovation, we spark the interest into digital health, as well as achieving the universal health coverage. So we also plan to provide these courses as with the support we would get from Ministry of Health and responsive institutions like universities who have it in responsibility to give competent health workers, both digitally and clinically, to feature our courses on their CPD. So on the Google form, you can see there is this question that how important is digital literacy for the future in health care, and 85% they agree that this is important. So this is not even to leave alone those small percentages. It shows people who do not understand how digital health is important, and that's even a gap. So how are we then addressing that gap at medical care? We are now conducting different webinars like the one we have on coming Sunday, where we feature our digital health experts, academicians, to speak to the youth in digital health, speak to the youth who do not understand the importance of digital health. So we see that as an increasing awareness, of course, on digital health, to have at least 100% next time. So before featuring the courses, we need to have the environment, the users who are ready to use it. Yes, so the question also asked, like, would you be interested in taking short courses, digital health courses with certificates? So 91% said yes, still 8.6% maybe no, and maybe, no, we do not have anyone saying no, but also maybe shows a gap too. So then, we tried to see, those are the courses that WHO recommends to be in e-health and m-health. So we asked them, what would you like to learn more about? So these are among the courses that were chosen among many others, and this is where the shows mHealth and eHealth is really important. And these courses, they are being categorized into two umbrella by WHO, which is eHealth and mHealth. Sparking and convincing why now in mHealth and eHealth is needed. So, yeah, Rwanda is investing much in digital innovations, as Dr. Menlas said. King Faisal was honored to, to see the machine being used in neurosurgery that uses AI. And we do have many others. We do now investing in telehealth medicine, like Rwanda Intelligence Center now. They are developing a telemedicine center so that they could provide even the healthcare services to the remote hospital. And this really tells how much Rwanda is investing in digital health. So as the healthcare workers need to be digitally competent there to keep up the innovations, to keep up the movement. So as I told you, the platform that was called NEMDSI, which is Next mHealth and eHealth Digital Skills Initiative, we provide a solution designed for healthcare students and professionals. So built on WHO digital health competencies and digital DCOD framework, it will be accessible on online platform to be able to be used by anyone regardless of their location. And because we've seen that if we bring our courses physically, there are going to be some restrictions because we do have more than around 7 universities. How then could we use this? So we see and then web application, something which can be accessible online to be much more convenient to everyone. So yeah, some of the limitations we had, our case studies involved medical students, and we understand that also we needed to have healthcare providers in place, but it was really so much harder to have the healthcare providers filling the form due to that they have different activities, they are doing duties in the hospitals. But healthcare students were more accessible through student associations. Now we partnered with Medical Student Association, Pharmacy Student Association, and as well Nursing and Midwifery Student Association to make sure that this research was possible. So we plan to pilot the scope or the future larger scale research needed also to include the healthcare providers. So universities then was recommendation should embed our courses in their curriculum, and government and partners should fund it to be more accessible and having the features to take. Because we understand that building a web application, it costs a lot, but really the results are really promising. So this platform can standardize digital health competence nationwide. And also during Africa CDC, I was honored to see how better then we can scale our solution, not only to address Rwanda's context, but also to see how we scale it to other countries for everyone in Africa to access it. And as well speaking their challenge, because now the problem we have in digital health, sometimes the solution that worked in other countries, we are trying to come up with it in our country, yet the contexts are so much different. So that's why doing the research, first of all, it helps you understand what is exactly the context are you going to put your solution so as to modify it accordingly. So as in conclusion, Rwanda's future healthcare leaders must be digitally fast, which are digitally competent. And the current student faces the gap in trainings, and this threatens our movement, because now Rwanda is really doing great, but what's then coming in the future once we, the people expected to navigate the tools and lead the system, we are not equipped to do so. Yeah. So, as in closing, integrating digital health skills is not only building a digitally competent workforce, but also it's the biggest step to achieving universal health coverage. Thank you so much for your kind attention. Looking forward to see you joining us.
About 10 minutes to open a discussion on 3 very different but very relevant topics. So for those of us joining online, you're welcome to raise your hand if you have a question, and we'll start with those of us who are here in person. So does anyone have any question? You can just turn on your mic and ask.
I think I've gathered the perspective really involving this hospital, and I would like them to respond to your question. Digital health skills concerns really more than electronic health records. We do have data analytics, which every healthcare provider, we've seen that research is really important, and universities are putting more efforts to advance research, but we need to be able to even analyze the data we have, because now you can have the data, but you cannot read them. You cannot see what's behind the numbers. And that's what we really actually need from healthcare providers. We do also need data science in health. We do also need AI. We do actually need also the most really very important mobile health, which we've seen that it's really important to achieving universal health coverage. As we've been in Africa CDC training, I was able to see how mobile health is really important, and developing mobile health application that can be accessed by anyone, regardless their digital literacy, and how it's going to even reduce those long lines you see in the hospital, and many of the patients are really seeking really so much simple information. So we see digital health then it's still really important.
Thank you. So
I'm an anesthesia student from Kigali Polytechnic. Now I'm serving as an ambassador of Ingazi. The question goes to last speaker, Gaston Ndagijimana. As he mentioned, Rwanda is really investing in youth opportunities, but he shows the recommendation about weak academic integration. And then, according to the statistics he already presented, he shows that youth, they need digital skills, and they also, which will provide certificates, and there is no anyone from youth who do not need digital skills. And then I asked myself, have you ever look or find the gap or the weakness of youth or student in acquiring that digital skills? That's first. The second, it's like my recommendation. It's a really interesting medical. Medical Go. He is the founder, and then they deliver lessons which is being similar to any courses from Ingazi. So I asked myself, as we are in collaborate, is it possible to collaborate with Ingazi? Ingazi, it's a platform designed by Minister of Youth and Arts in collaboration with the UNICEF. As also they provide the free courses related to what Ndagijimana Gaston said. It look to be similar. It's a digital skills. They deliver those skills, those courses for free. And then, as you can see in statistics, the youth who already acquired those skills, they are still few. It's free, but they are few. And I asked myself if there is no gap in or weakness of the youth or the students. Thank you.
Some of them are sent home within a day or two of delivering.
So what mechanisms can we use to track them postpartum and also educate their family members to recognize this? Thank you.
Of the community, creating awareness, both at the community level, the family level, and within once they come to the hospital. There should be adequate family support, and not just maybe after delivery you discharge them. We have what we call like follow-up. Just the way I'm suggesting, I'm thinking like when a child comes for immunization, the mother also like this normal 4 weeks, 6 weeks, 10 weeks, the rest of them, there should be created a room for the women also to be assessed their mental health, not just after the 6 weeks postpartum attendance or care, you just leave them. So I think that our health system should inculcate the activity of monitoring the women till 6 months postpartum. Thank you. I hope that answers your questions.
The most population of the healthcare providers faced with the digital skills, it's financial constraints most of the times, and he mentioned the NMDSI, as a solution to the issue. And then my question is, how does that project address the financial constraints that these people meet, in order for them to acquire these, the digital skill?
Yeah, thank you so much, Clever, for the question. I would like to seek more clarity before, giving you the solution. Like, whom do you speaking for? Like the healthcare providers? You mean the users? Whom do you think like those financial constraint concerns to?
Okay, my issue concerns most of the students, all of the time the students now, because as you mentioned, they are the ones who are now stepping into the long life career, and
So yeah, I would answer this in terms of saying maybe the fees for subscription to learn the courses. Yeah, if so, we are actually partnering with universities and Africa CDC and other partners to first of all support the students' financial problems in assessing the courses, and as well that we help them to access the courses without any other like financial demand. So speaking of that, then that's why we are seeking partners to work with us before, and then so that students, we understand we do not have jobs, and and we could even work with PED who provide some some disbursement during monthly to provide even extra for accessing the courses. Everything can be possible with discussions. Thank you.
Maybe we just make people to deliver more and to have more babies for the countries that are limiting the number of population, like highly populated countries. So maybe what do you think about that? Maybe it's one factor that limits people to make more babies. That is one. And the other thing, so assessing those psychological or mental health issues, did you engage a psychologist, and did they use the DSM-5, like just to know which category of mental health issues they have, or just you say mental health, mental issues? That's my two questions.
I don't know why I find this very funny, but I would still answer them. Reducing the number of childbirths, I don't think is going to limit the mental health problems among pregnant and postpartum women, because definitely every day there should be coitus interruptus and things that happen that we cannot really avoid. Okay, I think whether it's the first child or the second one, mental health problems can occur at any level. So even while pregnant or after post-delivery, during the postnatal period, it can occur. So it's not something that we can avoid, but it's so that we are finding a way to reduce the effect, the incidence. So And sorry, can you repeat the second question? I think I got.
No, I mean engaging psychologists. Did they use the DSM 5 or 4 just to classify those psychological issues?
Yes, they did. I engaged them and they used it before I was able to develop my own questionnaire. Thank you.
Mr. Gaston Bagijimana, your theme, your title was Digital First, Equipping the Next Generation of Health Leaders with Tech-Driven Problem-Solving Skills. And I saw you are implementing something like NMTI that's going to be like a CPD accrediting online, maybe if I can call it institution. But the question is, how are you going to maintain this with this AI developed world where everything, when my brain seems to fail, I ask AI, whether ChatGPT or other AI tools, to help me answer or do the tasks you can post there on your online training institutions. Thank you.
I have the thoughts before joining the Youth in Digital Health Network by Africa CDC. But what I learned I could share with you is that what we ask and what the responses we get, they are from AI. AI does not speak from our context. It's something to respond to anyone regardless. And then having then healthcare providers, as I thought before, technology is not going to replace medical doctors or human resource, because you know what? We do think accordingly and we address the problems according to what you have on the ground. So then investing what AI knows into human resource, we are going to get solutions that speaks directly to the challenges we have. I don't know if I answered the question. So let me decide then, it's still very important regardless.
Yeah, I like maybe this project must be so much interesting. I really appreciate that. Though he asked like one question. One was the question and the second was the recommendation. To confirm with you, you asked like what might be the constraints for youth to maybe take these courses, digital courses. Did you ask maybe the constraints, maybe or barriers or challenges for youth to taking these courses? So you can please and make a confirm.
Take like 10 seconds.
10 seconds.
Okay. You say the government of Rwanda really invested in youth opportunities.
Yeah, one of the things that hinders all the uptake or the solutions we put on the market, it's not even concerning this one only, but if you do not create what we call the market, possibly we are not going to get the solution we anticipated. So to do that, we did not start with the mobile app that providing the courses, but we started with the awareness, where we are now increasing the awareness of the importance of digital skills through the webinars we conduct, so as to create a way forward for once this digital platform is ready on the market, really the students knows how much important it is. We are now creating the market, the users who are interested. So about the collaboration with Ingazi, one of the things we put in place, it's what we call interoperability, to not just bring a solution over others, to see rather how they can connect and how they can be complementary. So yeah, we really thought that even we do have many others that provide courses on digital skills, but the difference we put in the consideration to know if we have some complementary work with them, and we provide what's really missing. We are just addressing the gap. It's not another app that is coming. Thank you.
Thank you very much. So, So before I go into my closing remark, I wanted to just give a brief overview of what Africa Health Sciences University is, because we're a new university. We're just over 1 year old in Rwanda, and we have upcoming now over 200 students across 7 different programs. And I wanted to highlight those programs. So we do have a Bachelor of Science in Midwifery, and we actually have some of our students here today, so hope you get a chance to meet them and hear more about their experience. Maybe if you can just wave your hands. These are our midwifery students at ASU. We also have 6 residency programs. We have emergency medicine and critical care. We have internal medicine, pediatrics, anesthesia and critical care, general surgery, and obs and gyn. So these programs are open globally, and so if anyone in here is interested in any of our academic programs, please visit our website, please check out what we're doing, because there's some exciting things coming through ASU. So I wanted to just highlight that. My co-chair, Dr. Gaston, is also our head of postgraduate programs, so if you're interested in residencies, he's the right person to talk to. Great. So as we close, I have some people to thank. We have these amazing partners here, and I wanted to highlight a few institutions and individuals, starting with Rwanda's Ministry of Health. So we really want to thank them for the significant support, not just in this event, but really through the whole 4x4 national strategy to quadruple the health workforce. It's a really exciting time to be in Rwanda, a lot of support going into health workforce development and systems strengthening. So we thank the Ministry of Health. Yes, thank you. We would also like to thank TORG and specifically Prof. Adabusola. This wouldn't have come together really without your perseverance and determination and just your collaborative spirit working with us. So thank you so much. Thank you for choosing Rwanda and King Faisal and for helping us strengthen this partnership. And also to all the volunteers of TORG. There's many people who have volunteered their time to make this event possible. So thank you so much. Next, I'd like to thank IRCAD Africa. IRCAD has been a longtime partner of King Faisal Hospital, and we're really happy that it has now expanded to include TORG. So thank you for your collaboration, both in training and also providing this beautiful venue for us to have today's event. And we look forward to more activities here with you. Thank you. Next, I would like to thank Kigali Top Events. So they're the ones who have helped us with the event planning, the transport, so many things behind the scenes that oftentimes we don't see, but it's a lot of work. So thank you to Francis and the team. We really appreciate you. And we do have some flyers, so if any of you are interested, you have events coming up, we're happy to link you. Also, we have the team in the room, so they're happy to meet with you after. And then finally, I want to thank a person in the room who is not just our dancing queen, but she has been managing so many things behind the scenes. She has had many sleepless nights. I don't think she slept last night. And still is here dancing and fishing for men. So thank you, Idel. We really appreciate everything you've done. All right, so this is concluding our presentations for today, but we have 2 more days fully virtual of so many interesting presentations and sessions. So if you're not in the WhatsApp group, let us know. But otherwise, please check in our WhatsApp group for the agenda and the links and all the details so that we're here online together tomorrow for more sessions. And then finally, for the rest of the day, we are going to now leave all of our things here. We're going to get up and go to the main entrance, and we're going to take a group photo together. Okay, so please leave all of your things here. We'll take a photo, and then we have a tea break, which is more networking time. So because the next 2 days are online, this is your chance to link with people and interact in person and network. and from there the day is officially closed. So thank you all so much for coming. We really appreciate your participation and hope this is the second event of many more coming through this partnership. So thank you very much. We will now get up and go for group photo.